Hello, and welcome to the MIMS Learning Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell, and I'm medical editor at MIMS Learning. Today, I will be speaking with Professor Carolyn Chew-Graham about supporting people with severe mental illness in primary care. She is also Professor of General Practice Research at Keele University. Her areas of expertise include primary care management of people with mental health problems, unexplained conditions, and the mental well-being of clinicians. Last year, she was awarded an OBE for services to general practice and primary care research. So, Carolyn, welcome to the podcast.
Thank you very much. It's good to be here. It's good to be talking about this topic. And just to say, I'm also a practicing GP.
So when we say severe mental illness, what do we mean?
So severe mental illness, or SMI for short, and I'll use that abbreviation if that's okay during this podcast. So SMI includes schizophrenia and bipolar disorder, but also other conditions where the person suffers from psychotic symptoms.
What are psychotic symptoms?
Okay, so there are three main symptoms of psychosis. One is hallucinations, and this is where a person hears or sees or occasionally feels, smells or tastes things that don't exist outside their mind. So other people are not aware of those sensations, but it feels very real to that person. And the most common hallucination that we talk about is hearing voices. So people are hearing voices that aren't there. Second main symptom is a delusion. And this is where a person has a strong belief that's not shared by others. A common delusion is that someone believes there's a conspiracy to harm them, and a person can appear very paranoid. And lastly, people who've got a psychotic illness have disordered thinking and speaking. So a person's thoughts and ideas come really quickly. Their speech is very fast and it can be confusing, and we sometimes call this flight of ideas. And so the person listening to the person who's got this disordered thinking and speaking gets confused and starts to wonder, is it they who have the problem? So as a clinician, when you're having difficulty understanding what somebody's saying, does it make sense? They might appear a bit paranoid, then think, is this a psychosis? So when people have a combination of hallucinations and delusional thinking, this causes severe distress to the individual, but also to the family. And it causes a change in behaviour, and it's often the behaviour change that's noticed by families. So, for example, a younger person who stays in their room all the time. I remember going on a visit to somebody a few years ago, and they were undoing all the screws on the electric sockets and the light fittings because they thought they were being listened to. There was a conspiracy that somebody was listening into their conversations. And so when people experience symptoms of psychosis, it's referred to as having a psychotic episode.
Okay, so how do these people with SMI present to their GP? Because first of all, there's still so much stigma about mental illness that I suspect if that you're hearing voices or you're having paranoid thoughts, you're going to be even more reluctant to talk about it with your GP than you might be if you're experiencing low mood or anxious thoughts.
Absolutely. So people can be ashamed of these symptoms, and that is related to the stigma of mental illness. They might not feel that the symptoms they're having are a problem, so they don't consult. So people may be taken to a GP by a family member, a parent, if it's a young person, or people present in crisis. So they present at the emergency department or to the police or ambulance services.
You were saying there about that someone with severe mental illness might be brought to their GP by a family member. I can imagine that's actually incredibly difficult for the family member to get their loved one to the GP because the loved one will refuse to go.
Yeah, absolutely. So family members might be concerned about the behaviour of their loved one, but that if that person has no insight into their problems, then the family member may contact the practice and say, we've got concerns, and that they're not able to get the family member to come to an appointment. Sometimes GPs will go out on a visit to assess somebody. But I think because of those difficulties around people having insight into their symptoms, it often takes a crisis, so police are involved or the person is taken to the emergency department by an ambulance. But some people do present, some people do have insight into the fact that things aren't quite right. So they may have low mood, they may have anxiety, they may have intrusive thoughts. And so they may present that to the GP.
You said at MIMS Learning Live in Liverpool that older people with depression might go to the GP for something else. Like they might be saying they're generally unwell, but actually it's because they've got depression. Can that happen as well? That somebody who's experienced no paranoid thoughts, they've gone to the GP saying it's a physical illness, but actually what they're really worried about is they're having these thoughts. Can that happen?
Yeah, so people may have symptoms as part of their delusion that actually they've got some significant health problem. So they may become preoccupied with their bowels or with avoiding certain things to eat. They may display obsessional thoughts and behaviours. So when people present to the GP with any sort of mental health difficulties or persistent physical symptoms that we're not able to explain, it's important for the GP to try and unpick that. Always have at the back of your mind, is this a psychosis? Could this be a severe mental illness? So, for example, people with bipolar disorder, it can take 9.5 years since the first presentation of symptoms until a diagnosis is made. And they have presented to the practice, they've presented to health services, they might have had talking therapies for low mood or anxiety or stress, but it's nearly 10 years when they get a diagnosis. And for bipolar disorder, the charity Bipolar UK have actually got a symptom check on their website, and it's worth clinicians having a look at that to think about the sort of symptoms they might ask somebody to discover whether they might have an underlying bipolar disorder.
And just to say to listeners, we will be putting a link to that resource in the resources page of the module of the podcast. I think you're saying that, like, being mindful that, is this a psychotic episode? Are there any like real red flags that this person might be having a severe mental health episode or worsening mental health?
It's more about taking a really good history, and obviously that's difficult in a 10-minute consultation, and it's often really difficult when we're doing online consultations or telephone consultations. But I think there are the 4 areas that the GP should be asking about in anybody with a mental health difficulty. So, functioning, cognition, what are you thinking, what's your mood like, and what's going on in your head. And so the sort of questions that I ask are things like, have you had any thoughts that are bothering you? Are there things that are happening that you can't explain? Do you think you might be seeing or hearing things that no one else is aware of? Have you felt lately that people are talking about you? So those sort of questions are quite broad, but they do allow people to disclose symptoms that they might have been worried about. They might be concerned that they're a bit silly, they don't want to talk about them, but you're asking an open question, and that helps people to disclose their concerns. It's also really important to ask about family history of severe mental illness, because there is a link, and again, particularly in bipolar disorder. And it's really vital to ask about drugs and alcohol. And then important to ask about self-harm behaviour and suicidal ideation. So we know that at the onset of a psychotic illness, people are really at risk of self-harm and suicide. But there are also other risks to the person that the clinician needs to ask about. And it might be that you're not able to cover this in one consultation, but you might bring the person back in a week's time because you're significantly concerned about them. So is there any evidence of neglect? Are they eating? What do they look like? Are their teeth cleaned? Have they got clean clothes on? Again, substance misuse. And their physical health, have they got already comorbid physical health problems, or are they at risk of developing other physical health conditions? And then also risk to others, so particularly children in safeguarding issues. And domestic abuse and violence, but often a person with schizophrenia or bipolar might actually be at risk of being a victim. They might be vulnerable. It's really important to see if there is a collateral history. So has the person been brought by a family member? Let's see what they've got to say. And if they've come on their own, then asking permission. I'm really worried about you. Is it possible for me to talk to your parents? Who do you live with? Is it possible to talk to them? But sometimes people who are developing a severe mental illness have gone on that sort of downward trend where they've perhaps become estranged from their family, or they've gone to college, they've left home, and then they're living on their own, or they're living in shared housing, and there aren't any carers around. And so it isn't always possible to get a collateral history. I think the key thing is, if you suspect that somebody might be developing an emerging psychosis, you really shouldn't wait and see. You need to think about, is this a psychosis? I need to get a management plan in. And that might be, I'm going to see them in a week, or it might be they need to have a referral now because they're at risk of self-harm or suicide.
You were talking about, they were being presenting in crisis. I mean, what should the GP do if they're thinking this person is going to injure themselves or someone else and they're going to be doing this now?
Yeah, I mean, I think it is important to say that crimes committed by people with severe mental illness are rare, and they do make the headlines because they're rare. People are much more likely to help themselves because of the paranoid ideas. They're often got thoughts in their head saying that they need to hurt themselves. So if the GP feels that this person is at risk of self-harm or suicide, if they don't have any protective factors, and if they've got no insight into their symptoms, then the GP needs to refer them to the crisis team or the home-based treatment team, and that might be called different things in different areas. GPs should be aware of the care pathway in their locality to be able to refer somebody for acute care. Mostly crisis teams or home-based treatment teams are responsive and will see people at risk. Sometimes they're overburdened, they don't feel that they can see somebody on the day, and then, we resort to calling a 999, getting an ambulance and taking someone to A&E. That's not ideal because A&E is a very busy environment and can make people more distressed. But sometimes that happens. If there's no acute risk, so if the GP feels, I'm worried about this person, I think they might be developing a psychosis, but they're not at risk of neglecting or harming themselves, there's no evidence that they might harm others, I'm going to see them in a week, I'm going to assess them, but I do think I need to refer them to the early intervention in psychosis service. And those referrals can be made urgently and are usually picked up fairly quickly. And we know that there's early intervention in psychosis services in every locality, and we know that early treatment of psychosis leads to much better outcomes. So it's really important that we as GPs get to know how to refer to an early intervention in psychosis service. So these services are multidisciplinary, they're community-based teams, and they try and keep people at home. They support people with a case manager, they have psychiatric input to give advice about drugs and medication, and there's usually early intervention in psychosis is offered for 3 years. So stabilising people, offering family support, offering CBT, and then discharging at the end of that, either to a community mental health team or back to the GP.
So now going on to physical illness, because you mentioned about that they might have comorbid physical health conditions. It's a known thing that people with severe mental illness die a lot earlier than the general population. What are the reasons for this?
Yeah, so we know that people with severe mental illness will die 15 to 20 years earlier than the general population. And this is mostly due to cardiovascular disease and diabetes. So whilst suicide does happen in the acute phase, early presentations, the mortality gap is mostly due to long-term physical conditions. And this might be linked with inflammatory processes which are linked with the development of the severe mental illness, because we know that inflammation in the brain is a contributor to SMI. But there are other factors. So poor diet, people may not look after themselves, I mentioned neglect already. Limited physical activity, smoking and alcohol use. So these contribute to the increased risk of cardiovascular disease and diabetes. But also the antipsychotic medications that we prescribe cause weight gain, they cause dyslipidemia, and that again predisposes people to diabetes and heart disease. And we know that this cardiometabolic morbidity starts early. So people started on an antipsychotic may gain as much as 12 kilograms in the first 12 to 24 months of treatment. So it's important to intervene early when somebody starts on medication, give advice about diet, give advice about smoking, check their weight, think about physical activity, not just wait till the weight piles on when it's really difficult for people to then lose weight.
One of the things I would have thought, though, if someone with severe mental illness, they're ill, they're very stressed because they're ill and they're having to deal with all this. Is that really hard for them to take on these sort of lifestyle advice, because it's kind of like the last thing they want to be thinking about, but maybe they just want to get through this period in their life?
Absolutely. It doesn't seem a priority for them when they're ill. It's not a priority necessarily for their family members. They want to see that person back to their previous self. They don't want to think about trying to help them stop smoking or restricting their diet. And it's probably not a priority for doctors. Psychiatrists are really keen to get the symptoms under control. And when people are back under the care of the GP, is that patient's mental health controlled? Seems to be the priority, rather than I also need to attend to the physical health. But GPs and other healthcare professionals working in primary care do have a role in supporting the physical health of people with mental illness. So half the people who've got severe mental illness are no longer under secondary care. They're under primary care alone. And the Quality and Outcomes Framework dictates that people with severe mental illness should have an annual physical health check. And it's really important that people are invited in and that we try and make our appointments as accessible as possible. Possibly it will need a home visit to go and do some bloods and to try and forge a relationship with the person. There's something called the Leicester Positive Cardiometabolic Resource, which talks about the physical health standards that we need to look at, that we need to screen. So we need to do blood tests, we need to check blood pressure, we need to ask about alcohol and smoking. But then what we need to do is we need to also intervene. And I think general practice is very good at doing the checks. Often healthcare assistants are delegated with that work. I think what we're perhaps less good at is following that up. So if someone has got an HbA1c, following it up with some dietetic advice or weight management. If someone is a smoker, have we got smoking cessation services to refer to? Well, often they've been lost during austerity. Does the practice have capacity to offer smoking cessation? Well, not all practices do, and we're not commissioned to do that. But I would emphasise the Leicester message, which is don't just screen, intervene.
Okay, so you were talking before about sometimes somebody with a severe mental illness has been brought to a GP by their loved one or a family member. What could the carers of people with severe mental illness do to support their physical health?
Yeah, so ideally, if they do have a carer, bring the carer into the health check with a healthcare assistant or whoever's doing that, talk about smoking, see whether the carer's willing to get involved in supporting smoking cessation, because quite often people who are stable, who've got SMI, do actually want to stop or reduce smoking, and they are receptive to it. And the research evidence is that you can support people with severe mental illness stop smoking if you can offer them a tailored, very flexible support package. Certainly if somebody lives at home with their parents, then you can discuss with the family the sort of diet that's needed, thinking about controlling alcohol use. I think it's also important to remember that the carer's got a tremendous burden of looking after this loved one with severe mental illness, and we don't want to be piling more responsibility on them. We want to offer support to them. Carers have an increased risk of mental health difficulties, so it's important to have a carers register, but it's also important to act on that register. So if a person comes in with their loved one who's got severe mental illness, asking how they are. Do they need another appointment to discuss how they're feeling? Do they need to be signposted to social prescribing or to NHS talking therapies to talk through the difficulties they've got? We often add responsibility to carers, not just around severe mental illness, but we need to make sure that carers are supported as well.
In the module that you wrote for us on smoking cessation in people with mental illness, you sort of talked about how smoking increases the metabolism of many psychotropic medications, and therefore if somebody on antipsychotics stops smoking, the doses need to be adjusted. Can you explain a little bit more about that?
So it is important for the GP to be aware of this as a possibility, but GPs may not feel able to adjust medication. Some antidepressants, such as duloxetine, and some antipsychotics, such as olanzapine, haloperidol, will be influenced by smoking and smoking cessation. And if a person stops smoking, the drug doses need to be reduced. And for me as a GP, I would like recourse to specialist care to say, how would you reduce these doses? What do I need to do? And it's really important to follow up a person who's got severe mental illness taking an antipsychotic. And because if they start smoking again, the metabolism of the drugs will be increased, and therefore you need to increase the dose of the drugs. So it's quite complex. Many GPs will feel that's not really within my remit. I don't feel confident to do that. Some practices have really good relationships with their local community mental health teams, and can therefore have conversations with psychiatrists about prescribing. The other drug that is affected by smoking is clozapine. That is prescribed and administered in specialist care, so that is definitely sits within the specialist care remit.
It sounds like you need to build a good relationship with the person who's got severe mental illness to get them to the stage where they can be discussing, their symptoms of the mental illness, and, perhaps talk about their physical health as well. I mean, what can GPs do to build a good relationship with someone who's naturally might be a bit paranoid and suspicious of you?
I think that's a really good question, and I think it's tricky in today's general practice. We've got bigger practices, access is often through online queries, many consultations are telephone based. I firmly believe that you need to see somebody face to face when they've got mental health difficulties, to observe them as well as to be taking a history. And I think you often need more than one consultation to establish what's going on. Even when someone is presenting with sort of anxiety symptoms or depressive symptoms, I don't think it's acceptable to do a one-off consultation, prescribe, get them to self-refer to talking therapies, and then you never see them again. I firmly believe that it's important, as the NICE guidelines suggest, that we should be offering proactive follow-up, establishing a relationship, booking the patient back in with you after a week or a month, whatever is deemed suitable in that person. Getting to know the person, finding out about the family, being aware that if somebody, say, you saw who's got low mood, doesn't really respond to antidepressants, you start thinking, well, actually, might this be bipolar disorder? Have I missed drug misuse? Gosh, is this an emerging psychosis? And that takes time and effort and a number of consultations. When somebody with severe mental illness is stable, I think they do need ongoing support from the practice, and that might be the GP. It might be one of the new roles, additional roles and responsibilities, so mental health practitioners, focused care practitioners, who establish a relationship and support the person, maybe signposting to social prescribing for more sort of social support. But the person with severe mental illness needs to have a link in with the practice, so that they feel if there's a problem, if there's a crisis, they know that they can come back to the practice. They feel secure. They don't feel they have to repeat their story again.
And finally, in the module on smoking cessation, you also mentioned oral health, and that the fact that people with severe mental illness have worse oral health than people without severe mental illness. Can you talk a bit about that?
Yeah, absolutely. And I think this is really neglected. And I'm not saying that GPs, we're not dentists, absolutely, but we need to be aware of the importance of signposting people with severe mental illness to dental services, because we know that people with severe mental illness may not brush their teeth, they may not have access to dental services. A lot of the general population don't, but there's a real health inequality in people with severe mental illness. They're much more likely to lose their teeth or have decayed teeth, to be admitted to hospital because of dental problems. But also we know that if you've got poor oral health and gum disease and you've got diabetes or cardiovascular disease, then there's an interaction. And so poor oral health makes diabetes worse, diabetes makes oral health worse. And so you've got a triple whammy in somebody with severe mental illness. So whilst I'm not saying GPs should be inspecting people's teeth, absolutely we shouldn't. But when a person with severe mental illness consults, either with a healthcare assistant for their health check, or with a GP for a medication review, or with a GP because they've got some other intercurrent illness, just be aware that mentioning, have you got a dentist? Would you like some help getting one? There's usually a telephone number that people can ring or can go online. Obviously, some people may not be able to go online, and there is a thing about digital literacy and digital inequalities. But just encouraging people to brush their teeth, to have a conversation about the importance of oral hygiene, about avoiding sugary drinks, and that's not just for the teeth, it's for the possible diabetes, and just make it part of that assessment, so making every contact count.
Well, thanks so much for speaking to me, Carolyn. Do you have any final thoughts or final messages for our listeners?
Yeah, absolutely. I think whilst GPs and practices are very good at delivering the quality and outcomes framework targets around severe mental illness, we can tick the boxes, we can do the tests, we're perhaps less good at following up, less good at intervening with a statin or with metformin or with dietary advice or smoking cessation. So I think my message would be, don't just screen, intervene.
Thanks again, Carolyn, for that fantastic interview. Do check out Carolyn's module on supporting people with severe mental illness to stop smoking. It's already had lots of views. Lots of people have already looked at it, so it's been really popular. And all of the resources that Carolyn has mentioned will be in the resource section of the module version of this podcast. So thanks again, Carolyn. Do join us next time when we'll be having a studio discussion about scalp and hair problems.